This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2019, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is the ABCDEF bundle and the role of the respiratory therapist. Dr. Wesley Ely is a professor of medicine at Vanderbilt University Medical Center and the Associate Director for Research for the VA Tennessee Valley Geriatric Research and Education Clinical Center in Nashville, Tennessee. Dr. Ely discloses relationships with NIH and VA funding, Orion, Pfizer, and Abbott.
Yes, my name is Wes Ely. I'm an intensivist at Vanderbilt University, and I work at the VA hospital, which I'm very proud to serve the veterans there. I know later in the morning you're going to have something. At 9 o'clock this morning, there's going to be something for those who serve in the armed services, and I think it's a wonderful tribute to them. It's the least that we can do. You know, back in the late 90s, about 20 years ago, before some of you were even born or were just being born, there was really a revolution going on in critical care. And it was started by some of the leaders that you know so well, Jamie Stoller, Dean Hess, Rich Branson, Bob Kazmarek, and others in the field of respiratory care. And I, as a student of them, began designing randomized controlled trials to try and contribute to that revolution. The main way to tell, I think, about a revolution is to tell the story about what would have generated the need for it. So I'll just start this morning, after I show my disclosures, I'll start with a story from one of my patients. My disclosures are shown here. I'm a physician scientist at Vanderbilt University. I received honoraria from a few companies that do CME activities. I don't care if you use their products. I don't have stock in those companies, but I always disclose anyone who gives me those things. My disclosure to you is that my comments today will be evidence-based, based on the peer-reviewed literature and not my opinion. And I think that's the commitment that I have to make to you this morning in order to give you an evidence-based lecture that you can trust the data on. I'm also the PI for several different ongoing NIH-funded studies and am NIH and VA funded. This is our SIB Center, the Center for Critical Illness, Brain Dysfunction, and Survivorship. And we 90 people at Vanderbilt and at the VA, and we have others in other institutions around the country, are committed to doing what we can to generate data that will inform you and me about how to do a better job for our patients. And the talk I'm about to give you is going to review with you this revolution I was talking about that changed the way that we care for our patients in a way that is super evidence-based, and I think fits beautifully with Dr. Egan's quote that Tom just gave us. He talked about senses and observations. I love that. And Dr. Egan would have been a perfect example of somebody who did pay attention to what mattered to the patient. And we have to use our senses and observations at the bedside to do the best job that we can for our patients. So a story. When I was training, I remember a patient named Teresa Martin. They've asked me that I could use her example in teaching, so it's not a HIPAA violation. Teresa came in with a an overdose, an attempted suicide, developed bad ARDS, was on the ventilator, and we blew her lungs up too large with tidal volumes that were too big back before 6 versus 12. This is the late 90s, early 2000s. And she ended up getting pneumothoraces, was immobilized, sedated heavily, tied down. And you know this scenario, it's extremely common in critical care. And she ended up actually even getting calcification in her joints from immobilization. And this sort of treatment of a human, I look back on now and think, wow, how did we think that it was okay to do something so undignified, so dehumanizing to a person as tying them down, immobilizing them, sedating them for weeks on end? She literally had that happen to her. Now, we know that sometimes we need to do that, and you respiratory therapists are helping me to stabilize patients' oxygenation when they are in rip-roaring ARDS. But the truth of the matter is that we are now using data to revamp the way that we care for the Teresa Martins of the world, and I'm going to take you through a bit of those data today. This is a patient who was the last person enrolled in the Mind USA randomized control trial, which was just published in the New England Journal of Medicine. In a few minutes, I'm going to show you the data from the Mind USA study, which is so relevant to you and the patients you care for, because think about how often your patients are getting antipsychotics and other treatments for profound, ongoing, acute brain injury, ICU delirium. This guy was the last person ever enrolled in the first ever phase 3 placebo-controlled trial of antipsychotics for delirium. The second patient, Mr. Baker, Mr. John Baker, I've also been given permission by him to use his example, is a soldier. This picture was taken in our VA hospital when I was his doctor just a few weeks ago. And there's a neat story that goes along with this that has to do with our armed services. But Mr. Baker's story is that he came in with an NSTEMI, got profound sepsis on top of the NSTEMI, was on the ventilator for multiple days. Here you see Mr. Baker looking at the camera, but unfortunately profoundly delirious. This guy's a RAS 0, CAM positive, didn't know where he was at the time of this picture, was very, very upset. He was starting to use profound language that he normally didn't. He wasn't interacting well with his wife, etc. Now, I went back and showed him this picture after he was no longer delirious, and he didn't remember taking this. His wife was at the bedside right now giving me permission to take this picture, and so he's obviously signed forms to allow me to use the picture now, FYI. This is a quote taken from Dostoevsky's Crime and Punishment. In that book, which I just read last summer, Dostoevsky uses the word delirium 31 times. Read, "Strange to say, he seemed immediately to have become perfectly calm, not a trace of his recent delirium, nor of the panic fear that had haunted him of late. It was the first moment of a strange and sudden calm." Now, for we clinicians, we immediately go to, well, was he calm because his brain was on at this point? Or did he get like Mr. Baker just was when I showed you in the last picture, apparently calm but brain off and hypoactively delirious? Hyperactive delirium, pulling out lines and tubes, upset, frustrated, diaphoretic, DTs, on a ventilator, whatever. Hypoactive delirium, calm, brain off, sitting in the bed, minding your own business. "Mr. Smith, are you feeling okay? Are you breathing okay?" You get a nod, yes, no. You have no idea what it means because the patient has no idea what you asked him or her. We now know that that delirium, that calm, hypoactive delirium, is the strongest predictor. Remember these 4 things. Strongest predictor we have in critical care of death, length of stay, cost of care, and an acquired dementia. For every additional day that somebody spends hypoactively delirious, they have a higher chance of death by 10% and long-term dementia by 35% per day. So 3 days of that, you do the math, you're pretty much going to have cognitive impairment, and you have a 1/3 extra chance of dying, irregardless of your other elements of severity of illness, like lung failure, cardiovascular, renal, etc. This is the picture that Mr. Baker gave me of his father, and he asked me later on when he was no longer delirious. I told him I was going to Paris in a few weeks to present the data that I'm about to show you. You're only the third people to ever see these data. I showed them in Paris, then I showed them in the Netherlands for the European Delirium Association, and you are the third large group that we have presented these data to outside of the public who got the paper in the New England Journal. But anyway, he said that his father was one of the men who came in just after D-Day and the invasion on the Normandy coast. And would I do him a favor and maybe take his picture to the beaches there at Normandy and let the tide wash the picture away? And we'll come back to that story in a little bit. Engel and Romano were two of the earliest investigators of delirium, and I dredged up this quote from their 1959 paper to share with you. Engel and Romano wrote, in 1959, 60 years ago, the problem of delirium is far from an academic one. Not only does the presence of delirium often complicate and render more difficult the treatment of a serious illness, but also it serves the serious possibility of a permanent, irreversible brain damage with increasing life expectancy and with improved survival through the influence of surgery and antibiotics. Do we know how often? And they go on to pose multiple questions. Many of the questions that they posed, I'm about to answer for you. Now, many years later, in 2018, we have developed the randomized control trials to find out the answers about how to care for your patients, when you go back to your hospital on Monday or tomorrow, whenever that is, and you're at the bedside with Betty Smith or John Doe. I want to give you some answers so that when you walk out of the door today, you can have a better feel for how to approach these things. And I'm going to give you two main answers: management of delirium and the overall management of the ventilated patient. This revolution started back in the late 90s by these leaders of the AARC, and it's really my great privilege to be here today to share with you some of this. So back in that time, you can see in this graph that people didn't have delirium on their mind. And when I was reading the articles of Stoller and Hess and Kasmerick and Branson and others, I began to ask the question, isn't there a better way to handle these patients? And so we invented a way to measure delirium called the CAM-ICU, the Confusion Assessment Method for the ICU. Raise your hand if you measure delirium in your ICU on a routine basis. Wow, pretty good. Pretty good, okay. And raise your hand if you use SBTs, spontaneous breathing trials, in your ICUs. Okay, the way this started was in 1995, I read a paper in the New England Journal by Andres Esteban. And in that paper, it said, they were reviewing different ways to wean patients, and it said 75% of the patients couldn't be enrolled in this weaning study because they were ready for extubation. And I said, whoa, wait a minute, what? 75% on this Monday couldn't be enrolled, then why weren't they taken off the day before that or the day before that? And so I thought, let's just protocolize this. That's when I went to your literature, and I read about weaning protocols with respiratory therapists. And we designed the first ever controlled study of routine screening for SBTs and routine turning off the ventilator every day to see, all done by respiratory therapists. And in 1996, I and my colleagues published this paper in the New England Journal of Medicine. It had the word spontaneous breathing trials in the title. And actually, that was actually generated by the editor of the New England Journal. I didn't think of that. Martin Tobin and others thought of putting spontaneous breathing in the title, and then we began to call these things SBTs. So that was in 96. In 2000, we thought about doing spontaneous awakening trials, which is the same thing as turning off a ventilator, but now you turn off the sedation, and we called that an SAT. And then we put the two things together and created the ABCs, Awakening, Breathing, Coordination, ABC. And that was the birth of this ABCDEF bundle, which I'm going to show you about in a moment, with data from 15,000 people showing reductions in death, length of stay, cost of care, less bounce backs, less delirium, and very cool, less transfers to long-term care facilities like nursing homes and LTACs. So we have an evidence-based way to do better care and get incredible improvements in clinical outcomes. And what it boils down to is you working with the nurse and the doctors and the PharmDs, all as a team in your units, using something like the evidence-based ABCDEF bundle. I call it the A2F bundle. And I'm going to share that with you second half of this talk. I'm also going to try and stop early to take questions. So permit me, please, to move a little fast through some of these slides. Before I get to the outcomes data, I want to show you the data behind why we think this is such a huge public health problem. In 2013, we published these data from the brain ICU study in the New England Journal of Medicine. 1,000 patients enrolled, and what you see here, look at the green line going across the top, and notice the boxes are way below the green line. What you see on the right of the graph are that people over 65 who are in medical and surgical ICUs leave the ICUs so that 3 and 12 months later, they have cognition that is way worse, way lower than normal, the normal being the green line. And if you look to the left of the graph, you can see data about those below 65 also having very, very bad cognitive function even a year later after ICU stay. These people didn't come in with cognitive dysfunction. They came in as an elective API or a community-acquired pneumonia on a ventilator, et cetera, and we screened out a pre-existing cognitive dysfunction. Now, the editor of the New England Journal said, well, Wes, what about those who are 30 and 40-year-old? Could they also? So look at the left of the graph. 30 and 40-year-old people who by no means should have abnormal cognition in the area of Alzheimer's disease and TBI level dysfunction do. Let me go back one. Did you notice that at the bottom there is a red line and a magenta line? That's TBI and AD. So these people have cognition in the realm of Alzheimer's disease and traumatic brain injury. And the 30 and 40-year-olds do as well. And what's really striking, on the next graph, I'm going to show you this divided up multiple other ways. And I'll show you one graph. Look at the top left graph. And you see that that is an area that's abnormal as well. That top left graph are 30 and 40-year-olds who came in with zilch in the way of pre-existing illness of any kind. So a perfectly healthy person coming in the hospital for an elective or an emergent illness and leaving, and a year later having a dementia. This is what we're the most worried about. And we found that delirium is the strongest predictor of this dysfunction. So delirium, the duration that a patient is delirious drives this cognitive dysfunction. You and the AARC are very, very in control of a huge piece of this delirium. Because did you know that early mobility, which is the E of the ABCDEF bundle, E is early mobility, the E is getting your patients on a vent who fail an SBT, still need their ET tube, getting them out of the bed and walking them. And that cuts delirium in half. And so you and how compliant you are with the bundle can help reduce the delirium and have this patient, every patient you care for, hopefully, have a better long-term outcome. Almost a half a century ago, this guy at Harvard, whose name was Ned Kassem, he was a stogie-smoking Jesuit priest doctor, actually, interesting guy. He said, let's start using Haldol for therapy of delirium. But we never tested it, and it was a cool idea, but we have now brought this forward and tested it. Other people have done some other studies in this area and shown that long-term antipsychotics increase the risk of death. And so I started thinking, wow, if we might be increasing the risk of death, we need to test these drugs. Listen to what Paul Wishmeyer, an ICU physician from Duke, says about being delirious, and think about if you would want this to go unmonitored if you were a patient in the ICU.
I think they realized I was delirious, and I remember them even talking about it, saying, we can fix this, and giving me Haldol. And I got the Haldol, and the first time I got it, about 15 minutes later, my room suddenly became very bright white, and I felt like I fell through 3 glass floors, and my body shattered on the ground of my now 3-level hospital room, and every piece of my body, which was glass, had a tag on it. And I had to walk up and down the stairs of my now multi-level hospital room, it seemed all very real at the time, and put my body back together piece by piece over the next 6 hours.
Pretty stark, right? Okay, I'm looking at the clock here. I've got 18 minutes left. I want to finish with 5 minutes worth of questions, so 18 minus 5 is 13. So I'm going to spend about 6 or so minutes on the next 2 topics. The first topic is antipsychotics, and then I'm going to do the ABCDEF bundle, the A2F bundle. What we need to do is create a world of critical care that provides a good crossing zone for our most vulnerable patients. And for the past 20 years of research, we at the SIB Center, Critical Illness, Brain Dysfunction, and Survivorship at Vanderbilt have been trying to do this. And I'm going to give you a summary of what we've discovered. This is the paper that we just published in the New England Journal in October. You can pull it up online now. It's going to come out in print version in December, I think, in the New England Journal. What we did was we took previous studies like the MIND, HOPE ICU, and REDUCE studies. These were pilots led to this. And we looked at the methodology. If you look at the bottom, you'll see two references, Gerard and Page. Gerard was our pilot study that looked into, can we feasibly study antipsychotics with a placebo group? And you can see in green, I wrote there, we had 33 people per group. It was a POIM study. It wasn't IV drugs. And it was prophylaxis treatment, which is a little confusing. The second study was a little bit larger, but the max dose of the drug was just 2.5 milligrams of Haldol. And a lot of people argued, 2.5 milligrams of Haldol, like we go up to 5, 10, sometimes even 20 milligrams of Haldol in a day or more. So that doesn't really test this drug the way that we give it. And so the next study was this study called REDUCE. They had a much larger sample size, but they did it only with prophylaxis, and again, only used 2 milligrams. So in the MIND USA study, which I'm about to share with you, we had 16 centers around the United States, and we did up to 20 milligrams a day of Haldol in the intravenous form like you would see it given in your patients. Double-blind, placebo-controlled trial, NIH-funded, enrolled patients who were on a vent or in BiPAP or in shock. We excluded them if they had severe baseline cognitive impairment, neuroleptic malignant syndrome history and couldn't receive an antipsychotic, or if they had torsades with a prolongation of QTc of greater than 550 milliseconds. They got randomized when they were delirious, and I'll show you who these people were. The two drugs that we used for the intervention were either Haldol or ziprasidone. Why? Haldol tests the hypothesis that is our traditional teaching. Read at the bottom of the slide. Dopamine blockade in the cerebral cortex improves cognition and reduces delirium. That's why Ned Kassem thought that we should give Haldol in his 1978 paper. But there are lots of other neurotransmitters that can go wrong in the brain. And so I wanted, when designing this study, to test other neurotransmitter hypotheses. Now, look up here just for a second. 3 major causes of delirium. Neurotransmission problems, which we're testing here. Blood flow problems, which go bad in sepsis with microthrombi. And inflammation. We're not testing the blood flow and the inflammation in this study. In this study, we're looking at neurotransmitter abnormalities, and we're trying to test the dopamine hypothesis of dopamine antagonism and multiple other neurotransmitters like serotonin, histamine, alpha blockade, and dopamine. That's the science behind this. So we screened 20,000 people. These are very difficult studies to do. We ended up with a very nicely sized large RCT, and every patient enrolled got tested. These people were about 60 years old. They were super sick with Apache scores in the realm of 30, which is massively ill. They were 95% on the blower, so these are your patients. About a third in shock. Med-surg was 70-30. Most people had ARDS, sepsis, COPD, CHF, or cirrhosis. The background therapy of all these people, you know, when you're in second grade and you learn what a randomized, and you learn what science is, the controlled experiment is just change one thing and leave everything else the same, right? So we standardized therapy here using the bundle. And most people got the bundle nicely. I'll come back to that in a minute. And the results were that after half of a century of using these drugs, we didn't see that anything was changed in the use of antipsychotics for delirium. You can see here that ziprasidone, Haldol, and placebo have overlapping durations of delirium and coma or delirium and coma freedom. Going further, no difference in mortality, and about a third of these people died by the end of 90 days, so a very sick group of people, but no impact on survival. and also no impact on duration of mechanical ventilation, ICU discharge, ICU readmission, or hospital discharge either. What's also interesting is that some of the people you care for might be hyperactively delirious, and others of them are hypoactively delirious. The hypers are those DT patients withdrawing from benzos or alcohol or narcotics, and the hypos are everybody else. In this case, the hypo patient, we broke it down by motoric subtype, no indication that there's any improvement in hypoactive delirium. And taking it a step further, no indication there's any change between the three groups in the pattern of delirium or the duration of delirium for hyperactive patients. So in conclusion, with regard to Mind USA, I'll give you three major conclusions. One, if you're giving an antipsychotic to your patient, don't do it thinking that you're reducing delirium duration. If you want to give it for some other reason, that's fine, but don't do it to say, I'm going to shorten their delirium duration. The A2F bundle is what you ought to focus your attention on if you want to reduce delirium duration. That's next. Arrhythmias, Parkinsonianism, neuroleptic malignant syndrome, study drug discontinuation, none of the safety things looked like a problem. So it's not like these drugs were a huge safety risk. However, they weren't improving duration. And lastly, these are viable drugs. If you go back on Monday and somebody's giving somebody Haldol or Ziprasidone or Respiratory, I think that's not malpractice. It's okay if you're doing it for either of these two indications: short-term control of agitation and severe anxiety when you need to avoid anything that suppresses the respiratory drive. So let's say you're trying to wean somebody off the blower and they're very anxious. Haldol, Ziprasidone, fine. Dexmedetomidine would be a way to go to. Anything that doesn't suppress respirations, because you're trying to get them to do what? To pass their SPT and come off the ventilator. So there you go. Now, Thomas Paine wrote in 1776, Common Sense, a long habit of not thinking a thing wrong gives it a superficial appearance of being right. In this case, I think this is what's been happening. We have superficially thought that we were doing something well, and for a long time didn't think it wrong, but lo and behold. So how to prevent brain-sapping delirium in the ICU? NPR did a 3-part series on this area back in October. And so if you go to our website, which is ICUdelirium.org, if you just Google ICU Delirium, you can find our website. And on our website are the links for these super interesting NPR episodes. And one of them incorporates this couple here, Richard and Kathy. And Richard and Kathy were my patients. He came in with 6 organs down, very sick, very ill, didn't think he was going to survive, but here they are after survival. And what we learned was that his brain-sapping delirium contributed to an ongoing dementia-like problem. And we have to do our best to reduce this. And we do that through a safety bundle. By the way, when you Google ICU delirium, if you misspell delirium, because there are lots of ways to misspell delirium, I've bought all the URLs for all the misspelled deliriums, and they'll all forward to our website. So I hope that helps. The ABCDEF bundle, the A2F bundle, I'll call it from now on, is based on 40 Lancet, JAMA, and New England Journal papers. About 400 papers altogether went into building this thing. This is not just warm and fuzzy. The alphabet may seem warm and fuzzy, but I just made it that way so that you would easily remember it. Face it, that's a sticky message, the alphabet. And Malcolm Gladwell says if you want something to tip, make it be rememberable and sticky. So we made this sticky. So A, analgesia. B, both SATs and SPTs. C, choice of analgesia and sedation, trying to avoid benzos. Delirium, early mobility, and family involvement. Did you know, for example, that early mobility cuts delirium in half? Expanding family visitation cuts delirium in half. Giving drugs other than GABAergic drugs, that's C, cut delirium down by 25 to 40%. SATs and SPTs together help get patients off the ventilator 4 days earlier and out of the ICU 4 days earlier. And analgesia is delirioprotective as well because pain is deliriogenic. So every one of these steps helps your patient's brain. So you thought that you were involved in respiratory care to take care of the clavicle to diaphragm ET tubes concept of the body. But in reality, Egan knew better. Senses and observations. Egan knew that what you were doing is caring for the whole person. And to care for the whole person, you have to respect their dignity and their humanness. And you cannot tie down a patient, leave them immobilized for days, and think that you're caring for them mind, body, and spirit. So if you have to do that, you have to minimize the duration of that and get them back to the land of the living as quickly as possible. And this sort of approach does that. Look, Beatles show is just down the road, right? Yoko Ono wrote to her son on this is in the Rock and Roll Hall of Fame, and I snapped this with my iPhone. P.S. The mind is a muscle. It needs exercise to strengthen it. She's basically saying, get out of the bed, walk, stop the sedation, do the A to F bundle, let's respect the whole person. And these are the 15 papers that we have published on this A to F bundle. So outside of the 400 individual manuscripts and the individual RCTs, even after we put this together as a bundle, there's all this literature there. And the Dr. Dre is right there for you to use every day. I wrote to Dr. Dre. I said, Dr. Dre, can I use your name to teach a mnemonic of how to evaluate and take care of delirium? And Dr. Dre didn't write back, and I'm taking that as a yes. So if your patient has delirium and they are CAM ICU positive, then you just say, let's run the Dr. Dre. Disease remediation. Does this patient now have a newly found sepsis, iatrogenically, COPD, CHF? Is there a drug we should remove? And let's look at this patient's environment. Let's get them out of the bed, mobilize them. What about eyeglasses, hearing aids, sleep, etc.? This is how we reduce delirium. Super easy. And here you see patients walking back in the 70s and now in the modern time. Unfortunately, in the middle there, many of you will remember how we didn't do this well. We didn't have our patients walking with their husbands beside them. Here in Poland, putting all their junk in a grocery cart. So don't tell me you need fancy equipment. But what does the bundle do? Well, individually, and we can go back to Dostoevsky here, he writes, until today the patient had been in delirium. No doubt the presence of his family had a favorable effect on his recovery. Whoa. The world's greatest literature is even saying, let's incorporate the family more often in our care. And this study by Troglerick of 21 investigations in delirium found that to reduce mortality, look at the second bullet, programs with 6 or more implementation strategies were best. A, B, C, D, E, F, 6. Boom. It's following the literature. Here in our study of 6,000 people, and I'm about to show you 15,000 people, but here in 6,000, you can see on the left a graph of survival, and on the right, a graph of delirium, coma, freedom. Freedom, look up here. Coma, delirium, normal. So how often is the patient normal and not in coma and delirium? And what you can see on the left is that you go across the x-axis and have more compliance with the bundle, you see an improvement in survival. 15% improvement in survival for every 10% increase in compliance. That's crazy. The numbers pan out, though. And on the right, also 15% improvement in delirium freedom for every 10% improvement in compliance. But could this pan out in a larger study? So we took on this study of 15,000 people in the ICU Liberation Collaborative put on by the Society of Critical Care Medicine. 68 ICUs, 15,000 people. All over the country, we did this for 2 years. And get this, as you go up in compliance on the Y, you get improvements in ICU discharge, less time in the ICU. You also get improvements in hospital discharge. As you go from 0 to 50 to 80% compliance, more and more likely to get out of the hospital. You see reductions in death. As you go up the graph, you see reductions in death. More performance, more compliance with the bundle, less death. We're seeing this consistently over and over again. Why is your hospital not enforcing the bundle, not enforcing these sorts of things? Do you want your pilot on the airplane to skip the safety checklist? Do you, as a patient, want your doctors and respiratory therapists to not run through this checklist each day? Because you can get, as you go across the right, reductions in delirium, reductions in coma. Interestingly, you'll see a bit of an increase in pain report. Why? If I'm awake and not delirious, I can tell you about my pain. How cool is that? I can tell you about my pain. And wouldn't you want me to tell you if I was in pain? So the bundle drops in time on ventilator, drops in ICU admission, drops in discharge to facility. We have flow sheets that you can fill out and use on rounds each day. And let's get back to our last two patients and I'll close. The last patient, this gentleman ended up surviving without cognitive impairment. Why? Well, it wasn't because of antipsychotics. It was because he got an aggressive bundle each day he was in the ICU. This gentleman, John Baker, the day he was delirious, I noticed he had been wanting to read. He reads the biographies of all of the acting presidents. And on his bed desk there, he had a book each day, but he wasn't reading it. And I said, why not? And he goes, my glasses are broken. I was like, oh my gosh, I teach about this all the time. And here is a pair of glasses in my pocket that I did not give you. So I reached in my pocket and I gave him my glasses. He was profoundly delirious this day. The next morning, I walked in. He was there with my glasses on his face, reciting for me chapter and verse all the things he had read in that biography of Roosevelt. Look how he underlined it and outlined things. Incredible brain on. This is what we have to do for our patients. Pay attention to the details. And this is our SIB Center website, the ICU Delirium website. We want to be at the forefront of discovery and innovation, improving the lives of people affected by critical illness with you. Dr. Raul Gomez from Buenos Aires told me last year and said I could use this quote. The classic care, your care, of critically ill patients is similar to a dementia factory. It is up to us to close the factory. We have an ICU recovery center, a post-ICU clinic, where we take our patients and bring them to the clinic for their care for the next weeks or so before we hand them off to their primary care practitioner. Go to our website. We're happy to help you. Write to us. We'll do anything we can to help you implement these things. Remember, semicolon, it ain't over. And these people do leave with PTSD. But I've got your back. We should have our patients back. We must do that. I did rent a car and go to Normandy. And I went to where his father had come through on the beach. And I placed his picture with that cross on the rock there where John Baker had served in the 93rd Infantry, and put the picture down in the sand just like his son had asked me to do, and let the tide come and wash it away. We have to do whatever we can for the patients we're there to serve. Thank you very much.